opportunity for me to introduce our speaker from Mayo Clinic, graduate from American University of Beirut Medical, and now he's working in Mayo Clinic, and he's on the rise, and he's going to talk to us on a very important subject, I would say an almost forgotten subject, hypoparathyroidism. Dr. Jad has graduated in American University of Beirut, and now he's an assistant professor in Mayo Clinic. His main interest is diabetes, and then he branched out into bone and mineral diseases, and also has done part of geriatrics in endocrinology. So I'd like to thank Dr. Jad on the behalf of the Pan-Arab Thyroid Association for his kind contribution, and CME. Dr. Jad, the floor is yours, and you have all our ears. Thank you.
Thank you for having me and for inviting me. And I agree, this is a very important topic for us to cover. I'm sharing my screen with you. What I hope to cover today, first of all, I have no commercial disclosures, and we will not be discussing off-label use, although we will be discussing new therapeutics in hypoparathyroidism. So over the next 40 minutes, I have prepared two cases for us to discuss. With the combination of these two cases, I hope to demonstrate etiologies and manifestations of hypoparathyroidism, exploring the gaps in conventional management of hypoparathyroidism, and then we'll discuss the current and upcoming therapies for long-term management in hypoparathyroidism. So starting with the first case, this is a 41-year-old man with a history of hypoparathyroidism who presents to establish care. We had not seen him before. He is currently asymptomatic. 11 years ago, at the age of 30, he had a thyroidectomy for papillary thyroid cancer with lymph node metastases. He's had in the past 10 years 2 separate radioiodine treatments, and most recently his thyroglobulin has been undetectable. Right after his thyroidectomy, he had a low serum calcium and undetectable parathyroid and was diagnosed with hypoparathyroidism. I did not have the original labs that led to the diagnosis. But currently, he's on calcium with vitamin D, which is providing him with 600 milligrams of calcium and 400 international units of vitamin D per day. He takes 2 pills of this 3 times a day, so 6 pills a day of this combination. Calcitriol 0.5 mcg twice a day, and then cholecalciferol, vitamin D3, 2,000 international units daily. 6 months ago, before he came to me, his calcium was 9.9, albumin 4.1, and PTH was undetectable. I repeated his lab tests when I saw him. His calcium was 10.2, albumin 4.3, phosphorus 5.3, creatinine 1.4, 25 vitamin D is 33 nanograms per ml. And I did a 24-hour urine collection for calcium, and the calcium was 420 milligrams per 24 hours. Some of you may not be familiar with these units that we're using. This is the US units, but so I put the reference ranges over here for you to understand. So his calcium is at the upper limit of normal, phosphate is mildly elevated, and 24-hour urine calcium is very generous. So as we think through our discussion today, I want you to think, what would you have done for this patient as your next step once you look at these labs? Would you initiate hydrochlorothiazide, 25 milligrams once a day, discontinue his vitamin D, reduce both calcium and calcitriol, the active vitamin D, or would you consider initiating parathyroid hormone therapy in this patient? I'm going to come back to these questions and the answers later. But first, I want to remind ourselves what is hypoparathyroidism and how do we manage that. So if we remember parathyroid, which is basically controlling serum calcium, has an impact on 125 vitamin D conversion in the kidney, which would increase calcium absorption in the kidney, increase phosphate clearance, and increase bone turnover. In the situation where we have hypoparathyroidism and parathyroids are functionally or mechanically non-existent, we have decrease in intact PTH, which will automatically decrease serum calcium and increase serum phosphate, but also increase urinary calcium and reduce bone turnover. And patients with hypoparathyroidism have low turnover in their bones. The most common etiology of hypoparathyroidism is surgical. 75% of the cases are following surgery. Mostly these are thyroid surgeries, but occasionally parathyroid or laryngeal cancer surgeries. But we can also have functional hypoparathyroidism. Situations of hypomagnesemia or hypermagnesemia can contribute to functional hypoparathyroidism with reduced PTH excretion from the parathyroid glands. Rare cases of autoimmune hypoparathyroidism or genetic variants are present. Infiltrative diseases, granulomatous diseases can infiltrate the parathyroids and affect that. Mineral depositions such as copper or iron. And then less common causes are destructive from metastatic disease or idiopathic when you don't have another explanation. Since post-surgical is the most common, I wanted to give you an update on what is the epidemiology of surgical hypoparathyroidism. Even though this is the most common cause of hypoparathyroidism, this is generally not very common. So about 8% of surgeries in the neck result in hypoparathyroidism. This is very variable depending on the expertise of the surgeon and the expertise of the institution where the head and neck surgery is occurring. So it can be much less, closer to 1% in expert locations or much higher in other locations. Most of these, however, are transient. So 75% of them recover within the first year after surgery, and only 25% progress to being permanent hypoparathyroidism. Again, the most common is following total thyroidectomy, followed by parathyroidectomy. Less commonly, partial thyroidectomy or other neck surgeries such as laryngeal cancer. Manifestations of hypoparathyroidism vary very widely, and over here I listed all the manifestations of hypoparathyroidism that can impact really the entire body, because parathyroid hormone and calcium are important for function of many organs and many systems. I'm not going to go over these in details, but this is for your reference, simply to give you an idea that really hypoparathyroidism and hypocalcemia can impact many systems, including central nervous system with seizures, Parkinsonism or dystonia. The cardiovascular system can be impacted in up to 10% of people with cardiac arrhythmias and cardiomyopathy. Renal system quite commonly impacted, and we're going to come back to talking about the renal impact of hypoparathyroidism later in the talk today, including nephrocalcinosis, kidney stones, and progression of kidney disease. And then very common to see cataracts occurring early on in patients with hypoparathyroidism, and neuropsychiatric symptoms of anxiety, brain fog are also quite common. And so even with good biochemical control, so even after correcting for calcium and phosphate, we continue to have patients that are complaining from some alterations in mental function, brain fog, as I mentioned earlier, poor memory, poor ability to focus, poor concentration, what they report as mental fatigue. And so this brings up the concern that how can we help these patients beyond biochemical control? But with good biochemical control, we can control many of the symptoms that are related to tetany, cramping, paresthesia. So typically hypocalcemia-related symptoms can be well controlled with good biochemical calcium and phosphate control. To diagnose hypoparathyroidism, the guidelines from 2022 that were published following the international symposium tell us that we need to always remember to correct serum calcium for albumin, but we need to have a low serum calcium after correction for albumin and an undetectable or inappropriately low PTH. Very important for us to be using a second or third generation assay to measure PTH. So it's very important for us endocrinologists to be in contact with the lab because many of our assays are quite intricate, and we need to have a good communication with the lab where we're having these measurements to make sure what assays they're using, and this is also important for PTH. This needs to be repeated twice, so on 2 occasions, at least 2 weeks apart before making the diagnosis of hypoparathyroidism. Post-surgical hypoparathyroidism, since this is the most common, remember that what I mentioned earlier may be transient and patients may recover within the first year after surgery. And so we don't make a diagnosis of permanent hypoparathyroidism until 12 months following surgery. This used to be 6 months until the most recent guidelines in 2022 updated this to 12 months following surgery. The PTH level that is measured right after surgery is actually a very good predictor of whether these patients will progress to permanent hypoparathyroidism or not. If PTH is greater than 10 following surgery within the first 12 to 24 hours after surgery, it is much less likely for them to develop a permanent disease, and they can recover within the first year. Whereas if PTH is undetectable right after surgery, they have a good chance that this may become permanent and may not recover. As I mentioned earlier, you always want to make sure that magnesium is normal before making the diagnosis, because hypo or hypermagnesemia can cause stunting of the parathyroid gland and reduce parathyroid hormone excretion. And so very important for us to measure magnesium when making the diagnosis. Biotin, there is an epidemic of supplements that contain biotin. For various reasons, people are picking up supplements that contain high doses of biotin over the counter. And so biotin, the content in these supplements is so high, it can actually interfere with the PTH assay measurement. And this came up initially with thyroid hormone measurement, but we know also PTH can be affected by that. So very important for the patient to have held any supplement that contain biotin before measurement of PTH. So as I mentioned, how do you make the diagnosis? At baseline, you want calcium, you want PTH, always collect calcium for albumin. You always want to obtain creatinine, make sure what's the patient baseline kidney function is. And because hypo-PT affects phosphate, we want to measure phosphate. We measure magnesium, again, to make sure this is not functional. And then 25 vitamin D, because this becomes important to correct vitamin D when we are correcting serum calcium. Because there is increased calcium excretion, so you have hypercalciuria that develops, you want to measure 24-hour urine calcium and creatinine. And renal imaging at baseline is important to make sure the patient does not have any nephrocalcinosis at baseline. The guidelines recommend genetic testing only if the patient is diagnosed before the age of 40 and there is no alternative diagnosis. So this is not post-surgical, this is idiopathic before the age of 40 with a family history, or if the patient has other manifestations of a certain syndrome, such as autoimmune polyglandular syndrome. You may want to do genetic testing for those patients, but otherwise may not be needed. And how do you monitor the patients over time with hypoparathyroidism? So the labs that I mentioned earlier, we don't need to repeat them all the time. So the calcium, albumin, creatinine, phosphorus, and magnesium, because these are important to maintain always in the normal range. I'll come back to talking specifically about the goals of these ranges here. But if you have someone who is on a stable regimen, you only need to repeat them every 3 months. But calcium, albumin, creatinine, and phosphate need to be repeated within 7 to 10 days after any change in the dose of the calcium or calcitriol supplementation. Important to keep in mind what time of the day you are checking the calcium level for the patient. So you want to know, have they taken the morning dose of calcium before I have drawn the lab, or have they not had any calcium since the night before? Because that can impact the interpretation of those labs. I don't measure parathyroid hormone routinely, only initially to make the diagnosis, but then after that may not need to be measured. We do measure vitamin D to ensure they have a sufficient vitamin D level at least once a year. 24-hour urine calcium needs to be checked once or twice a year to make sure that this is maintained in a normal range. And then imaging of the kidney only initially at diagnosis and then every 3 to 5 years, does not need to be repeated much more often than that. And so how do we treat patients after we've made the diagnosis of hypoparathyroidism repeated twice with low calcium, low PTH, normal magnesium? How do you treat the patients? So over the next 3 slides, I'm going to list the different ways we manage hypoparathyroidism. And in each, I'm listing what is the goal of treatment with this agent. So obviously, because they have hypocalcemia, they need calcium supplementation. You could use either calcium carbonate or calcium citrate. The starting dose should be between 500 or 1,000 milligrams, at least twice a day, if not 3 times a day. Calcium needs to be given in multiple daily dosing. So 2 to 3 times a day, sometimes may need to go up to 4 times a day, because the patients need high doses of calcium and they will not absorb high doses in one time. So it needs to be split over multiple times a day, but also because the patients can have significant fluctuation of calcium. It can go very high and then drop very low few hours after a dose of calcium. And so to sustain the level of calcium throughout the day, they need multiple daily dosing. So obviously the goal of calcium is to alleviate symptoms of hypocalcemia so they don't develop any symptoms. But you want to target your calcium to be in the lower half of the normal range or just below the normal range. We're not targeting mid-normal or high calcium level. We need to avoid that and only target low normal calcium with our calcium supplementation. Calcium alone is not sufficient. They always need to have activated vitamin D. And typically in the United States, we use calcitriol, 125 vitamin D. The starting dose is 0.25 mcg twice a day, and then can be titrated at higher doses depending on calcium and phosphate. And so calcitriol also needs to be given in divided doses because it has a short half-life. So it does not last a full 24 hours. So that's why we give it twice a day. And the goal, again, the same target calcium. So we're targeting a low normal calcium, but also trying to avoid hyperphosphatemia because calcitriol can absorb both calcium and phosphate in the intestine. And so we need to make sure we're not going up too high on the calcitriol in order not to overshoot with the serum phosphate level. Thiazide diuretics, we use them quite commonly to avoid hypercalciuria. So the goal for thiazides is avoiding hypercalciuria. Goal 24-hour urine calcium is in women below 250 milligrams per day and in men below 300 milligrams per day. You can use chlorthalidone or HCTZ. If you're using HCTZ, it needs to be given twice a day. Remember, HCTZ is most commonly given once a day for hypertension. But for hypercalciuria, it needs to be split to 2 times a day. It will not be effective on hypercalciuria if it's given once a day. And so because these patients, if you've noticed so far, we have them on different agents. Each agent is given multiple times a day. It can be quite burdensome how many pills they take and how many times a day. And you may decide then if you want to make chlorthalidone once a day, that's much easier for the patient. Chlorthalidone is 24-hour active, and so you only need to give it twice a day. The doses needed for hypercalciuria are higher than the doses needed for hypertension. So often we need to go up to 50 milligrams or 100 milligrams per day, whether chlorthalidone or HCTZ, to be able to reach a good urine calcium. So these are higher than the doses for hypertension, and sometimes we're limited because the patients develop hypotension, so we cannot go much higher on the dose. Next is vitamin D. So cholecalciferol is the recommended way of supplementing vitamin D. We recommend just the standard replacement dose, so 800 units up to 1,000 units a day is sufficient. The goal is just to reach a target level, sufficient level of vitamin D. We don't want to overcorrect vitamin D because that can lead to hypercalcemia, obviously. And so that's why we monitor vitamin D levels in these patients. And as I said, magnesium is very important to keep it normal so that you don't have more risk factors for hypocalcemia. Many times we need to use magnesium salts such as magnesium oxide or magnesium sulfate replacement. And then the goal is simply a normal magnesium level in these patients. Two things to keep in mind. If hyperphosphatemia develops, I mentioned earlier, phosphate can go very high if we are replacing high doses of calcitriol. And so how do you manage that if phosphate is high? Calcium supplements, if they are given with the meals, they will serve as phosphate binders. And so it is recommended that they use calcium with the meal. That will help reducing serum phosphate. It helps to put them on low phosphate diet, and I usually refer them to a dialysis nutritionist to get discussion on low phosphate diet. Although these patients are not on dialysis, but this is where they have good experience in getting information about low phosphate diet. If needed, we can use other phosphate binders, such as Sivelamer can be used in this situation. I rarely need to use it though. If hypokalemia develops, hypokalemia is a side effect of the thiazides, especially chlorthalidone can cause significant hypokalemia. And so we recommend that they add potassium in the diet, such as bananas, potatoes, they are rich in potassium, or add potassium supplements. Or you may want to start adding another diuretic, such as amiloride, which is a potassium-sparing diuretic that can help these patients on top of the thiazide diuretic they are using. And so this is a summary on this table of everything I mentioned in the past few slides about how to treat the patients. I put an asterisk here that this is my personal approach. So even though this is adapted from the guidelines, I modified the doses. This is how I use, and these are the typical doses I use in my clinic. So I typically use calcium carbonate, and I start with 1,000 milligram 2 or 3 times a day. As I remember, multiple dosing is important every day, so not one dose, multiple daily dosing, preferably with meals to avoid hyperphosphatemia, as I mentioned. I use citrate, calcium citrate instead of carbonate only if they are on PPI or they have some other malabsorptive conditions, because citrate is better absorbed than carbonate. I tend to use a lot of chewable calcium. So we have chewable formats of calcium rather than the big pills of calcium they have to swallow. That makes it easier for them to take it multiple times a day. So I tend to use a lot of chewable calciums. There are liquid formulations that are available. If someone cannot tolerate pills, they can do the liquid. I'll come back to this in a second. Calcitriol, either 0.25 or 0.5 mcg twice a day. As I mentioned, I tend to use chlorthalidone over HCTZ because it's once daily dosing. I start at 50 milligrams once a day, and then titrate based on serum calcium, urine calcium, and monitoring potassium, make sure they don't develop hypokalemia. Magnesium oxide, typically only needed once a day. And then cholecalciferol, 1,000 IU once daily while monitoring vitamin D levels. So this is a typical regimen for patients with hypoparathyroidism that I see in my clinic. Some additional considerations. I talked to you, I mentioned briefly carbonate versus citrate. Carbonate has much more elemental calcium in it than citrate, and so they end up taking, if they need to be taking citrate, they end up taking much more pills. Number of pills will be higher to achieve the same level of calcium. But in randomized controlled trials, both carbonate and citrate were equally effective. So you can use whatever works for the patient. I tend to use carbonate more. I tend to tell them, as I mentioned, take it with food to bind dietary phosphate. Citrate, the one benefit of citrate that has been shown in research studies, it may improve urinary oxalate excretion. And so we don't have data on kidney stones, but potentially patients who do have kidney stones, citrate may be preferred, but we don't have really data to guide us there. As I said, citrate may also be preferred in someone with malabsorptive disease or taking PPI. Another consideration, patients who've been with a gastric bypass, for example, or taking tube feeds. This is something that we see commonly here in the United States. As I mentioned, I use chewable calcium because chewable will be absorbed up in with the saliva and in the upper GI tract. And so preferably in those that have malabsorptive disease or gastric bypass, this will be helpful. As I mentioned, liquid formulations are available for all three agents, liquid calcium, liquid calcitriol, and liquid vitamin D. But it's very important to dose it appropriately. So they need to dose the liquids very appropriately and measure it very strictly to make sure they're not overdosing with the liquid formulations. And so if you remember the patient that I presented earlier, this is the young gentleman who's had 10 years history of hypoparathyroidism. His serum calcium was on the upper limit of normal, 10.2. His phosphate was elevated as well. He was taking high doses of calcium and calcitriol. He was not on a thiazide, and his urine calcium was very elevated, 420 milligrams of calcium per 24 hours. And so all of these options could be considered. Would you initiate hydrochlorothiazide? This is a possibility, but as I said, I don't use it once daily. It would be twice a day. But he already has hypercalcemia, so this hydrochlorothiazide may make this worse. So the first step really is to reduce his calcium and calcitriol dosing because both calcium and phosphate are very high for him. So I will reduce his calcium and calcitriol, reach low normal calcium, not even in the mid-normal. We need it low normal. And then if he continues to have hypercalciuria, then I would initiate a hydrochlorothiazide. So my first step in this patient would have been to reduce calcium and calcitriol rather than immediately going to HCTZ that can worsen the hypercalcemia. Then I would repeat urine calcium and then decide on hydrochlorothiazide. In my slides over here, you can read the rationale of why the other options were not correct, and I decided to give him reduce his calcium and calcitriol, which was option C, and this is based on the guidelines that are quoted down here, the most recent guidance for these patients. And with this first part, I have covered the conventional therapy for hypoparathyroidism, how we treat patients, and what is the recommended goals for treatment for the patients. I want to shift gears and discuss another case to talk about a little bit beyond conventional therapy. What is missing in hypoparathyroidism management in 2024? So this is the second case of a 38-year-old woman. She presents to the ED with shortness of breath. For the past 4 days, she's been having a gastroenteritis with diarrhea, nausea, vomiting. Looking back at her history, she had a thyroidectomy at the age of 35 because she had a large goiter that was causing compression. And on pathology, she did have Hashimoto's, and they found a micro-PTC in pathology. And she's had hypoparathyroidism since her thyroidectomy, which is about 4 years ago. So she's now 38. At the age of 35, she had her surgery. Her current regimen is levothyroxine, 125 per day. She takes escitalopram for anxiety. Her hypopara regimen includes calcium carbonate, 500 milligram elemental calcium with 400 international units of vitamin D 3 times a day. And she takes calcitriol 0.5 mcg twice a day. So currently in the emergency department with her acute illness, she's afebrile, her blood pressure is fine, her heart rate is fine, and she did not have a Schwostek sign on examination. But she does have exhibition of some signs and symptoms of hypocalcemia. So her EKG showed a prolonged QTC for 82 milliseconds. Her labs show a calcium of 6.6 with a normal albumin, so she is hypocalcemic. This is below our target. So target for patients like this, as I mentioned earlier, would be in the lower normal range. So around 8.5, 8.8, up to 9 would be acceptable, but 6.6 is quite low for her. Phosphorus is quite elevated, 6.1. Creatinine was normal, PTH was undetectable. It was checked in the ED. And then her magnesium was also on the lower limit of normal, 1.6. And so when considering this patient, obviously in the ED, we think her acute illness provided some rapid deterioration in her calcium management. And so she will need IV calcium to correct her QTC and to correct her serum calcium. But overall, this patient, simply because she had an acute gastroenteritis, she ended up in the emergency room with hypocalcemia. So we see this quite commonly, patients coming recurrently to the ED with hypocalcemia, either hypocalcemic crisis, hypocalcemic symptoms, or like this patient, asymptomatic but significant hypocalcemia on lab testing and on EKG. So other than giving her IV calcium, what are your considerations for long-term management for this patient? How can I keep this patient from getting to the ED every time she has a flu or a little bit of nausea and vomiting that she cannot tolerate her medications? And this is not a multiple choice question. This is kind of open-ended question of what do you consider can help these patients? And this is something we've been struggling with for many years now in terms of how to manage chronically these patients. And this is where PTH replacement therapy comes into play. Hypoparathyroidism has remained so far the one endocrinopathy that does not have hormone replacement. Up till 2015, we did not have hormone replacement for hypoparathyroidism, and we were only managing with the end target, which is calcium and calcitriol. And so why is PTH replacement? As I mentioned, hypo-PT has been the last endocrine disease without hormone replacement. Many unmet needs in patients with hypoparathyroidism. Neuropsychiatric symptoms, even in someone who has normal calcium after correction for the biochemistry with the conventional therapy, they continue to complain of mood disturbances, poor quality of life, fatigue, brain fog, poor concentration. Renal function and skeletal function are things that have not been addressed with conventional therapy. I'm going to talk about these, how conventional therapy actually may worsen renal function, and what's the impact on skeletal function. And these are unmet needs in these patients, in addition to, as I mentioned, recurrent ED visits, hypocalcemic crises that can happen in these patients. This is a summary of multiple studies that looked at quality of life in patients. These are mostly observational studies, case control studies. Patients with hypoparathyroidism compared to controls or only hypoparathyroid patients, different areas in the world, Europe, India, USA, and the Middle East. And various questionnaires have been used, mostly the SF-36, which is something that has been very commonly used. And all of these studies have shown that patients with hypoparathyroidism has significantly disturbed quality of life, decrease in multiple domains in the SF-36, including depression, anxiety, well-being. All of them were decreased in these patients. Renal complications. This is a study that looked at patients with hypoparathyroidism starting at index time 0 and then progressing. This is months, so 5 years, 60 months after diagnosis. And this is looking at what is the proportion of patients with chronic kidney disease that develops over time. Hypo-PT is the one in blue, and control patients without hypoparathyroidism is in gray. So over a 5-year time frame, patients with aging developed mild increase in the risk of CKD. This happens with aging. But look at the proportion of patients with hypoparathyroidism developing kidney disease. So significantly higher proportion of patients with hypo-PT develop kidney disease, despite being on conventional therapy and well managed with conventional therapy. This is the proportion of patients who went into end-stage kidney disease over time, again, much higher rate in hypo-PT compared to controls. And this is the patients who had a decline in the GFR by more than 30% over the 5-year time frame. Again, significant increase in decline in renal function in the first few years after therapy. It plateaus a little bit later, but continues to be higher than in controls. And so in the first few years after hypopara development, we have a significant increase in the risk of chronic kidney disease. The second complication is kidney stones. So nephrolithiasis, again, proportion of patients developing nephrolithiasis following hypopara diagnosis significantly higher compared to controls. And then patients with nephrocalcinosis that is seen on imaging of the kidneys, another risk with these patients significantly increased from the beginning. It is quite significantly increased. We think both nephrolithiasis and nephrocalcinosis are not only related to hypoparathyroidism itself, because PTH is not present, and so there is no reabsorption of calcium, but also it's a complication of conventional therapy, because we're giving these patients large amounts of calcium and large amounts of calcitriol, so they are filtering a lot of calcium in the kidney every day, and then the reabsorption is not present because there is no PTH. And so we think that this not only is a complication of hypo-PT, but also complication of conventional therapy itself. Skeletal complications, patients have, this is, remember, I mentioned this earlier, this is low turnover. They have low bone turnover, so they develop a high bone mass. This is a microarchitecture of a piece of bone from a hypoparathyroid patient compared to control. So the mass of the bone, I hope you can appreciate visually, is much thicker, much denser. However, the microarchitecture is abnormal. They do have a tendency to have higher risk of fracture also, although the observational studies have been conflicting about the risk of fracture in these patients. Briefly, I want to mention what is the PTH therapy that is available or will become available. So in the next few slides, I'm going to mention a few of them. Humanized parathyroid hormone 1-34, very short half-life. This has been studied by Karen Weiner and the NIH, particularly in kids, but also in adults. But it needs to be given through an infusion pump. So they studied it by putting the human PTH into an insulin pump and delivering it continuously. It showed that it improved calcium phosphate and the calcium phosphate product and stabilized bone markers. And when it is delivered through a pump continuously, it normalized urinary calcium. But this did not come into the market. And so this was only available via research. Oral human PTH was available. It's been studied, a pilot of 16 weeks, open label, 19 subjects who've had hypo-PT for over 12 months. It is, again, very short half-life, so it needed to be given 4 times a day and titrated up to 12 tablets per day. Half-life of it was in minutes, 20 minutes or 30 minutes, compared to the injectable, which is almost 3 hours. But when given multiple times a day, it showed significant reduction in the need for calcium supplementation. 40% went down by more than 50% reduction in the calcium pills that they were taking. But they continued to require calcitriol. 24-hour urine calcium was decreased in only 20% of patients, but significant side effects of GI issues. Obviously, the pill burden, they needed to take up to 12 pills a day. So this is in the pilot study, these were the results. We have not seen it come to phase 3 trials yet. This is recombinant human PTH, not para, was available for a short period of time, for a few years, studied up to 10 years, very effective in normalizing calcium phosphate and improving quality of life, but it's been recalled in the United States, and the Kyowa Kirin and Takeda, who were initially marketing this, decided they will stop by the end of this year marketing this anywhere in the world. So this will no longer be available anywhere in the world beyond December 2024. And so even though we've had use of it for a few years, it's been off the market in the United States. It is still available in Europe and other countries and Japan, but it will be discontinued by the end of the year. And so we need newer agents, and these are the ones that are coming on the market. This is TransCon PTH. It's been named teriparatide. And just to give you an idea how it looks like, this is a carrier, an injectable carrier that brings in PTH into the subcutaneous tissue. The carrier is dissolved and goes excreted through the kidney. And then PTH itself is released into the bloodstream. And so it provides a slow release of PTH continuously over the day. PTH will act in the bloodstream on PTH receptors, and then the carrier will be excreted through the kidney. It's a slow kind of a sustained infusion, so there is no peaks and valleys, and it's as if it's giving you an infusion-like profile. These are the data from the phase 2 clinical trial using this TransCon PTH. At 26 weeks, 91% of patients went off calcitriol and were on less than 500 milligrams of calcium per day. So significant reduction in the burden of conventional therapy, significant decrease in 24-hour urine calcium, including normalization and quality of life. This was continued for an extension beyond 26 weeks with an open label study, and patients at 58 weeks remained off conventional therapy and urinary calcium remained in the target range. This is the phase 2 study called the path forward using this TransCon PTH. And so this is just details about the study, but these are the results over here. This is the mean calcium following the initiation of TransCon PTH. This is it remained in the low normal range on target, and these are the patient's urine calcium at week 26, and then with the off-label extension at week 58, urinary calcium remained normal. More importantly, the phase 3, which was a randomized controlled trial, randomized 3-to-1, 63 patients were on TransCon PTH and 21 received placebo for 26 weeks. And then it was continued for an open label extension after those initial 26 weeks. Again, looking at target calcium, independence from active vitamin D, and then looking at urine calcium and quality of life. This is the data of the first 28 weeks of the study. So placebo calcium was maintained in the low normal range, and then TransCon PTH were maintained in the normal range. Patients on TransCon PTH did not need calcium supplementation. The calcium dose went below 500 milligrams per day within the first month of therapy and remained below. They did not need to take additional calcium supplementation. Similarly, calcitriol was discontinued, and all of them stayed off of calcitriol throughout the 26 weeks of therapy, maintaining serum calcium in the normal range. This is the open label extension. The patients that were on the placebo group were given TransCon PTH, so it was a crossover period. And even those that crossed over from placebo to TransCon PTH became independent from calcitriol and very low dose of calcium supplementation. 24-hour urine calcium went down and remained low, and these are the different domains of the quality of life questionnaires. Everything was improved with TransCon PTH. And then the urinary calcium remained low with even with the open label extension study. It remained low below the target 250 milligram per day. The impact on the skeleton, as I mentioned, the skeleton is an issue with these patients. So we only have data on turnover markers. The turnover markers showed that the turnover increased. It became a high turnover state in the first 26 weeks and later tapered off. So there was a recovery period from turnover on the skeleton. We don't know the effect of that on the skeleton yet. Data on HRPQCT was presented as an abstract recently at ASBMR in the fall, but we don't have the full data yet. Overall, most side effects were very minimal, so mild or moderate side effects, nothing that was significant in these patients. And so to summarize this part, oral PTH in clinical pilot studies showed efficacy, but high burden of disease. So we will see if this goes on beyond pilot studies into phase 3 trials. But TransCon PTH appears to be very efficacious. TransCon PTH has been approved in Europe. In Germany, they have been using it for about 8 months now. It is not approved yet in the United States. And so we will have more experience with using TransCon PTH as it becomes available, hopefully later this year in the market in the United States. Couple of studies are currently in the pipeline. I will not go over them in detail, just to let you know there is more of therapies that may be coming. An analog of PTH receptor, so PTH analog that targets one form of the receptor of PTH, PTHR1, and keeps it activated all the time. So PTH activation at the receptor level. This is being tested in a phase 3 clinical trial now. And then an antagonist to the calcium sensing receptor is also being in now phase 2 and phase 3 studies. These are ongoing, so we will see what the impact of that will be in clinical trials. So to conclude my talk, hypo-PT is a rare disease. It is mostly seen following surgery. Permanent cases are rare, but they do happen. Conventional management works very well for biochemical control, but we continue to have burden on the patients with quality of life, renal impairment over time, and multiple ED visits. And so PTH replacement is quite promising what we have now, and we hope to get more data on the impact of that in the near future. And I thank you for your attention, and I'm happy to discuss these cases and any questions the audience may have.
Thank you, Dr. Jad. That was a very comprehensive and informative lecture on a subject we all would like to know, and we are all struggling to manage all the various metrics and parameters, plus not knowing how to follow up the patients effectively to avoid all these complications. On top of that, we are limited in giving the drugs, and the most the challenging part is to tell this patient to take so many tablets in a day. And the non-compliance, I mean, in diabetes, they say 25% in the United States, non-compliance. For hypoparathyroidism, so many tablets and huge tablets, I can imagine even more. And I would like to congratulate you also that you gave the attention about those patients visiting the emergency so often, and we think sometimes that they have a psychiatric problem plus non-compliance, and probably there are those percentage who require the new therapies or PTH. So I will embark on. We have about 7 questions for you to answer, and the first question is about the place of parathyroid transplant in patients who are not responding. What is your take?
So parathyroid transplant has been tried with very variable success. We have very limited experience and limited studies in parathyroid transplantation. Parathyroid autotransplantation has been kind of done very commonly. And this is typically, for example, someone where you're having thyroidectomy and the surgeon is able to identify the parathyroid gland, and they know because of the extent of surgery, hypoparathyroidism is very likely to ensue. And so they take an intact parathyroid and they transplant it in the same patient. It used to be in the forearm. Now they use the chest area, so it's easily accessible. And the hope is that it will develop its own blood supply, so it is taken with the blood supply, and then this will help. There is good results from this, and it does reduce the risk of developing hypoparathyroidism in someone in who you can predict this. The problems have been in this situation is sometimes it's very hard to predict who's going to need it, who's not. And so many surgeons don't end up doing it because they did not predict that this is needed. They did not know the extent of surgery that will be needed. Or the lack of expertise of the surgeon. So typically a cancer surgeon who's doing, let's say, an extensive laryngeal resection, they don't have expertise with the parathyroid autotransplantation. And unless they would have communicated with an endocrine surgeon beforehand or ENT that does these before, they may not know that. Parathyroid transplantation that is kind of non-auto-transplantation, so a donor parathyroid transplant. There is only one center in the US that's currently performing this. The volumes are very low and variable success. The data was not very promising in terms of how much they require anti-rejection medication. In terms of the benefit of that, they still continue to require calcium and calcitriol supplementation despite transplantation, donor transplant. And so experience has been very mixed with that.
Thank you. I'm muted. Yeah, the other questions are more related to when you're going to treat the PTH levels, when you're going to start the target level for treatment. I think you covered it very clearly. And hypophosphatemia related hypopara after surgery. At what level of phosphorus do you recommend starting phosphate binders?
Right, very good question. And I'm going to actually address a few questions that I'm seeing here in the chat at the same time. So when it comes to conventional therapy, your calcitriol dose is going to be limited with the hyperphosphatemia. It has to be given twice a day. If you're using alpha-calcidol rather than calcitriol, the doses, I believe, are the same. We don't use alpha-calcidiol in the United States, but the doses are the same as I have in my talk for calcitriol. In terms of the level of phosphate, it's really dependent on the kidney function of the patient. Someone with normal kidney function, you can tolerate phosphate up to 6.5, I would say. And this is a personal approach. There is really no guidance on that. But when it's coming close to above 6.5, this is where I start getting worried and start either backing off on the calcitriol if I can afford it, or starting a low phosphate diet on top of it, or then considering adding a phosphate binder such as sevelamer. The goal here is not the phosphate level itself, but rather the calcium phosphate product. So you multiply calcium by phosphate. And the typical thinking is that the traditional teaching is calcium times phosphate should be below 55 when you're measuring them in milligram per deciliter. Below 55 reduces the risk of nephrocalcinosis and deposits of calcium phosphate salts in the soft tissue. And so you want to use that as a guide, but also dependent on the kidney function. So it's quite complex. How do you decide that? But typically anything above 6 or 6.5, I start getting worried and probably introduce a phosphate binder. There was a question about HCTZ, and so yes, hypercalcemia could ensue with thiazides, and that's why you need to monitor that. And you would not start it in someone whose calcium is already high. You lower calcium intake first before adding a thiazide, as I mentioned.
Yeah, there's a question about the pregnancy and the use of therapy, including teriparatide.
Yes, very good question. So I actually debating whether I want to talk about pregnancy. So a few considerations when it comes to pregnancy. In pregnant patients, you have to automatically discontinue thiazide. So HCTZ is not recommended in pregnant patient because there are data on teratogenicity of that. So automatically upon diagnosis of pregnancy, we need to stop thiazide. Calcium, calcitriol can be given. Pregnancy state usually produces two things. PTH-RP starts increasing. It's coming out of the placenta. So there is a high PTH-RP that comes in. And so many patients who are pregnant may need a decrease in the dose of calcium and calcitriol because now they have an actual form of PTH, which is PTHrP, that is active in their system. Also, the level of 125 vitamin D increases in the system and remains high. It reaches 3 times as high as pre-pregnancy levels by the end of the 3rd trimester and can remain high during lactation period as well. So both PTHrP and 125 could be high. And so during pregnancy, you want to monitor the patient very closely. It's recommended that you measure every month calcium, phosphate, creatinine, albumin, magnesium, because they may need very variable titration. But on the counterpart, you have an increase in the volume of distribution of the patient, and so things get diluted. So it's hard to predict whether the patient will need up titration or down titration of calcium and calcitriol. And so we need to measure very closely, initially every few weeks, every week for a few weeks, and then every month after that. And remember, measure calcium in the baby upon delivery, and then every week following the 1st month of delivery for the baby to make sure they don't develop any hypocalcemia. Teriparatide, there is no data on it. So PTH replacement, there is no data during pregnancy. Any PTH replacement so far, no data during pregnancy. So it's recommended to be avoided.
There's a question about during therapy, basal ganglia calcification. How do we approach this issue?
Yeah, very good question. So basal ganglia calcification, we think, is also a combination of complication from therapy as well as from hypoparathyroidism itself. And so this is where that calcium phosphate product I mentioned becomes very important. We don't have data as to any reversal of basal ganglia calcification with any therapy that we have. We know the incidence is high in these patients, but this is why it's very important to target a calcium phosphate product that is below 55, a calcium level that is on the low normal, not high. So low normal calcium. And if you do notice these in the patient, then obviously the best thing to do is to try to minimize how much calcium and calcitriol that they are needing, keeping both calcium and phosphate in check.
Right. The issue of osteoporosis and the use of PTH. What is your take on this? Teriparatide with osteoporosis. You did mention, but they would like to hear from you.
A very good question. So these patients, as I mentioned, have high bone mass, but they may be amenable to fracture. And so if you have someone with hypoparathyroidism that does have concomitantly osteoporosis or fracture, how do you treat this? We already mentioned that this is a low turnover state. So it's actually a very good consideration to use PTH therapy or PTH analog, teriparatide or abaloparatide if it's available. They can be used, and then you will actually be introducing PTH for the patient that is for skeletal protection, but also may help with reduction in calcium and calcitriol dosing. If you were to use teriparatide as an off-label for hypoparathyroidism, not necessarily for osteoporosis, it has to be twice daily dosing. So remember, teriparatide is given once a day for osteoporosis, but the effect will not last as long for calcium and vitamin D. And so you may need higher dosing. But if you're treating only osteoporosis, I think that's a good idea because you want to increase turnover. Notice what I showed you when patients received TransCon PTH, there was an increase in the turnover marker in the first few weeks, and then it plateaued after that. We don't have long-term data. So this would be an off-label use to use teriparatide for a it will be a particular case where you could use teriparatide, but we don't know the long-term data. And what do you do after teriparatide? If you've given it for a couple of years, do you go on bisphosphonates afterwards? We don't have data to guide us there, but certainly could be a consideration.
So celiac disease is one of the rare diseases, and sometimes it comes over either immediately or over the time with hypoparathyroidism. How do we approach because of the absorptive issues?
Yes, yes, very, very good point. This is those of the special situations that I mentioned in one of the slides about malabsorptive conditions. So someone with celiac, I prefer that they take chewable versions of therapy rather than swallow the pills because the absorption is very variable. Obviously, they need to treat the celiac itself. If celiac is under control, absorption is better. But I tend to prefer having them use the chewable calcium, or the liquid formulation of calcitriol may improve absorption, may be better than the pills. And you'll have to monitor very closely. You may require much higher doses, including higher doses of cholecalciferol or vitamin D to get there.
Bridging the relationship between the endocrinologist or the clinician with the laboratory. Which assay of PTH you prefer? That's one. Second thing, during the monitoring of calcium, what instructions should we give the patient? Should they take the calcium tablets before or in the morning?
Right, very good question. When it comes to PTH, we're now using third generation assays of PTH. And so this is the preferred, but if you have the second generation, this is acceptable as well. It has shown good reliability. But older PTH, the word they used to call them whole molecule PTH, those are the first generation and are not as reliable. So intact PTH, second generation, third generation are the ones that are most reliable. When it comes to measurement, I usually tell the patients to have the blood test done after they've taken the morning dose. So don't do it fasting. Many times because I tell them I want to know what the calcium is after you've taken your morning dose. An hour or two later would be optimal after they've taken it. And if I see a calcium of 6 or 7, I tell them, have you taken your morning pill before? If they have not, then I simply get them to take it and then recheck it because they may not need adjustment of the dose. It could simply be timing of when they check the calcium level.
So the last two questions, Transcom, can it have efficacy on the bone for osteoporosis?
Right. The only data we have is what I showed you when it comes to turnover markers. We don't have data. The skeletal data has been presented at ASVMR. It showed stability, some improvement possibly in HRPQCT, the quality of the bone. This is short-term data, few months use of TransCon PTH. We don't have long-term bone density data. So very good question. We don't know, but I'm sure that there will be studies coming out to tell us about that.
So the last question, Dr. Ajad, we've exhausted you. Inflammatory bowel disease and inflammatory bowel disease. Can you hear? Inflammatory bowel disease, IBS.
I'm sorry, I lost you.
Inflammatory bowel disease with the calcium absorption issues. What is your clinical experience?
Right. So typically, we don't have much concern when it comes to IBS in terms of absorptive diseases. It's simply a transit-related issue. And so I have not had issues with IBS causing any change in the dosing when it comes to the conventional therapy. Inflammatory bowel disease, I'm sorry, I'm reading the question now. So inflammatory bowel diseases, yes, this is the same as I mentioned for celiac disease. So it would be chewables or liquids, much better absorbed than the big tablets because yes, many cannot tolerate those. I have the same experience. I use the chewables multiple times a day or liquid formulations.
We have this group of patients, females with IBS, and they come with a plethora of different symptoms, a very difficult clinical challenge. And I usually check their PTH as well. What is your clinical experience and mileage with such a group of patients?
So you're talking outside of hypoparathyroidism, correct? Elevated PTH. So we see this very commonly. Could they be
coming with the idiopathic hypopara and be part of the spectrum of IBS?
Right, right. So that certainly could be because autoimmune diseases can cause, so there is an autoimmune entity of hypoparathyroidism. And so certainly could be part of that. But with these patients, I also want to stress what I mentioned earlier, checking magnesium, making sure magnesium is normal. Then this is not a functional deficiency in PTH or functional inability of PTH to act on the receptor with magnesium deficiency that needs to be corrected rather than a true hypoparathyroidism.
So I would like to close the session now and thank you very much. Thank all the participants and the listeners. It's been a great evening and a knowledgeable period. Thank you to organizers. Thank you to Dr. Jad for your contribution. And Jazakallah khair. Ahsant. Shukran.
Thank you. Thanks for having me again.
Shukran. Shukran. Ma as-salam.